All right. Well, good afternoon, everyone. We are going to go ahead and get started. Sorry for a little bit of the technical delays. It wouldn't be a grand rounds without some type of IT challenge, huh? All right. Well, I am so excited to introduce to you all our nephrology fellow, Dr. Yariana Rodriguez. She's going to be sharing with us today. Dr. Rodriguez obtained her Bachelor's of Science in Biomedical Science from Pontifical Catholic University of Puerto Rico. She then went on and received her doctorate in medicine from Ponce Health Sciences University School of Medicine in Puerto Rico. And she completed her internal medicine residency in Wyckoff Heights Medical Center in Brooklyn, New York. Was there at the epicenter of it all during the COVID-19 pandemic, was one of those frontline physicians, and grateful for her work and her commitment to patients during that stressful time. And she's been such a tremendous asset to us here at Houston Methodist. We have been extremely proud of her, and it's just been such a privilege to see her grow and develop as a nephrologist. She will be graduating and moving on, joining our one of the private practice groups here in Houston, our Renal Specialists of Houston group. But we are excited about what she's going to share with us today. Yariana is such an advocate for her patients and really wants them to excel, giving them the tools that they need, educational tools, guidance. And so she's really going to be sharing a lot with us on specifically on nutrition and education that can be provided to our CKD and ESRD patients. So without further ado, Yariana, you can take it away, my dear.
Thank you, Dr. Evers, for such amazing presentation. Glad to see everybody join the Renal Grand Rounds. Today, we're going to talk about two topics that I'm extremely passionate about. One is CKD education, and the other one is nutrition in our kidney disease population. What the present is and what the future might hold for us. So just to run over the objectives that we're going to discuss today, the first one is going to be some general definitions on what patient education is, health literacy challenges, and general chronic kidney disease education. Later on, we'll shift gears to what nutritional guidelines are and some of the emergent trends in chronic kidney disease. And lastly, we'll discuss the role of a collaborative approach of chronic kidney disease education and explore some future initiatives. I know that people here in this Zoom are very familiar with what chronic kidney disease is, but just as a general reminder, CKD is defined as abnormalities of kidney structure or function present for a minimum of 3 months in total, with implications to health for our patients. And as we know, there are two major components to this classification. One of them is the GFR, or glomerular filtration rate, and the other one is albuminuria. It's important to understand what challenges poses on patients to progress on chronic kidney disease, because as we know, CKD is one of the top 10 leading causes of premature mortality in the United States, and its incidence continues to increase daily. As we all know, a staggering number of approximately 96% of the population in the US at some point in time might have mild to moderate decrease in kidney function. Moving on to some of those general definitions, what patient education means. Basically, the general definition is enabling individuals to make informed decisions about their personal health-related behavior. And its main goal is to aim improvement in overall health by encouraging compliance with medical treatment regimens and promoting healthy lifestyles. So how do we do patient education? So for starters, here we have a figure and I'll guide you through it, that describes the health belief model. This was a cognitive behavioral model that was developed around the 1950s, and it was based on the value expectancy theory in health education. That theory basically suggests that the subject placed value and their outcomes is going to be dependent on the expectation of an action that might lead to a healthier behavior. Whether the individual chooses to engage on that action that might improve their overall health or decrease the poor health that they have currently is going to depend on multiple factors. Initially, we have some of the modifiable factors, including psychological characteristics, which include personality and community and peer pressure. Others that are not so modifiable, such as age, gender, ethnicity, and socioeconomical status. How the patient perceives the threat that we are discussing, in our case, will be progression of chronic kidney disease. If they understand what the severity of this is, what susceptibility they have to progress on disease, and later on evaluate their behavior. What benefits do they have if they don't continue to progress on their chronic kidney disease journey? And what barriers do they have? After that, then we can evaluate what will be the likelihood of that health behavior to be obtained. And as physicians and educators, we can see what cues of action to perform so our patients can be guided through this journey. This health belief model has been adapted in many initiatives, such as smoking, health screening prevention, and also in chronic kidney disease education as well. So what are some of the barriers that possess patient education? As we know, health literacy is one of the big challenges that we have for our patients. It's important to understand that health literacy does not only engage the patient, it also includes organizational health literacy, and there are other components that we won't dive into this talk. To begin, we can define what personal health literacy is, which is the degree of which an individual, such as our patients, can find, understand, and use information and services to inform health-related decisions and actions for themselves and others. But we know that patients don't work alone. We also need a huge collaborative approach to entitled CKD education. And specifically, there is some talk of something called organizational health literacy, which is the degree of which the organization proposing the educational material equity enables those individuals to find and understand and use this information. So as we know, it is important to understand that these two main components of health literacy intertwine with each other and work hand in hand to provide optimal medical education and education overall. So interesting enough, here we have two figures that we're going to run over. This was obtained by the first National Assessment of Health Literacy in the United States by the US Department of Education back on 2003. And in brief, this summarizes some key findings and some policy implications to this assay. There were 3 literacy scales that they used to evaluate in this study. One of them was prose literacy, which basically was the knowledge and skill needed to perform the tasks that patients were asked to. Document literacy, which was basically the knowledge and skill for patients to perform documented tasks. And quantitative literacy, which is how they understand that material. If we find here in figure 2, the first one to the left, here we have the percentage of adults in each health literacy level. And as we can see here, most of the US population is between an intermediate, below, or basic. Only 12% of the population study was proficient, which signifies that we do have a health literacy crisis in the United States. And as we see here in the figure to the right, it has it divided by racial and ethnic groups. Important to notice is that, for example, in the Hispanic population, more than 50% of the population is going to be either basic or below basic health literacy. And this is not different in the Black population, where we see that 24% of patients are below health literacy and 32% are basic. As we know, there are many key social determinants of health that affect how CKD education is proposed. But if the patients that we're guiding to prevent them from further on increasing their CKD, then that means that we need to actually pay attention to health literacy when we are educating our patients. So why does health literacy matters in chronic kidney disease education? Here we have an article published from Jason which tried to really dive into what low health literacy, if it is associated with the onset of chronic kidney disease during the life course of patients. During this study, they evaluated data from a prospective cohort of around 93,000 community patients in the Netherlands. And then the authors that we can see in the visual abstract, they try to explain whether low health literacy was associated with the onset of chronic kidney disease in older adults. As we see here in the visual abstract in the bar graph here, as we continue to move forward in our CKD categories based on the estimated glomerular filtration rate, is the higher percent of patients who have low health literacy, meaning that there might be a correlation with low health literacy and CKD progression. They infer that this is related to how patients with low health literacy manage certain modifiable risk factors that leads to CKD progression, such as having a high BMI, having high blood pressure, and understanding their disease onset, and other modifiable factors such as NSAID use, tobacco, and alcohol use. Now here we have a picture that summarizes some studies that have been performed on health literacy and chronic kidney disease education. And it is a big table, so I want us to focus on two main things, the two red highlighted blocks that we see in the figure. In the first block, we see that the design of most of these studies are actually designs that take time to perform, such as semi-structural interviews and focus group discussions, which might explain why we don't have more research on how the impact of health literacy affects our chronic kidney disease population. And as we see here in the other second highlighted box, I want us to focus on those two main studies in their main results. As we see, most of the patients mentioned that self-managing these problems that can lead to progression of chronic kidney disease, they attribute that to having knowledge gaps, misconceptions of their disease, understanding that if they don't have symptoms, they're not going to progress in the disease. And it is important to understand this because we as educators and physicians can tie in those barriers for our patients and further prevent chronic kidney disease continuation for them. So here we have a second graph here that was one of the articles also published on JSON, which tried to investigate and address certain interventions leading to structural racism and reducing kidney health disparities. But this is no mystery to all of us. As we see here in the figure, we have upstream and downstream. In the upstream side, we're going to have determinants of health disparities. Downstream, we're going to have determinants of those health outcomes. And these are certain challenges also to chronic kidney disease education as well. We know that patients who might come from a low socioeconomical environment might also have some low health literacy, which impacts how our patients understand their disease process. Other social determinants such as environment, physical and social environment, and we're going to discuss how the community also plays a role on our CKD education. And all these factors intertwine and can lead to chronic kidney disease. And understanding how all of them play a role in our individualized patients might help us improve how we perform CKD education on them as well. Here we have another article which was published that tried to evaluate the associations of health literacy with self-management behaviors and health outcomes in chronic kidney disease patients. Basically here, they did a systematic review of all the studies they could find, and they evaluated around 48 studies. In their findings, they noticed that there was an apparent consistent relationship between health literacy and self-management behaviors, such as diet, fluid management, and treatment adherence for these patients. It also found an apparent relationship between low health literacy and prolonged kidney-related hospitalizations as well, meaning that there is a caveat on educating our patients to help prevent them have further hospitalizations and understand their disease process as well. So diving in a little bit more on certain health literacy challenges for our CKD patients, This was an excellent article published in AJKD back in 2015, and I'll guide you through this graph. Here we have on the y-axis the Lexile score, and the Lexile score basically evaluates two features of text that patients can read. One is going to be the word frequency, and the other is going to be the sentence in length. So they're typically presented in between ranges. So that's why we see the numbers here for the Lexile score. As higher that Lexile score, it means that the complexity of what is written increases. Now, the Flex KingCat grade level, it kind of estimates the US grade level required for the average reader to understand the text at hand. So as we see, the higher the number on that scale, the higher appropriate US grade the patient should need to understand what is being presented to them. And as we see here, this gray depicted area is where the average reader stands for. But we see a pretty big population here that they need to have advanced health literacy understanding to understand the educational material proposed to them. As a basic rule of thumb, patient education materials need to be pitched at a literacy level of around 5th grade, which is the appropriate level that a 10 or an 11-year-old will understand. And as we see here, we already have dived in that our CKD patients possess lower health literacy than maybe the general population, meaning that we are not meeting that cutoff of educating properly our patients. And likely it's because we haven't been adapted to their health literacy needs. As we all know, in any health disease process, there are many risk factors that can continue or progress our chronic kidney disease in our patients. Some of these factors are not modifiable, such as age, gender, and ethnicity. But as we look in this graph, there are many risk factors that can be modifiable. And through education, patients can understand better what these risk factors are and try to decrease the progression of CKD in our general population. Some of them are going to be diabetes, metabolic syndrome, using of nephrotoxins such as NSAIDs or other medications, and getting appropriate management on time. So here we have also part of the study published in SAGESN. And as we can see here, I want us to focus on the red blocks as well in hand. Some of those studies, the educational topic was related to risk factors that are well known to prevent CKD progression. Some of them are going to be NSAID avoidance, what is the protein intake, which we'll talk about in a few minutes, what is the health kidney function, and what dialysis modalities can they choose, and blood pressure control. And focusing on the right side of this highlighted red block, we see that the interventions performed during this successful CKD education efforts were mostly a collaborative approach, meaning that people like nurses, pharmacists, teaching sessions, group sessions, and educational booklets were involved in the process of those education efforts, meaning that we are not alone in this path as physicians. We need to utilize all the resources available to provide effective chronic kidney disease education. So chronic kidney disease education, we all know that if we have effective communication between our patients, their family, and the community that they are involved in, it improves patient understanding and builds trust between patient and provider. We also know that low health literacy and emotions can impair the educational processes in these patients. It is important for us as clinicians and educators as well to understand what are those barriers and try to read the room when we are performing educational interventions with our patients. So NIDDK came with two tools for providers to try to improve how we perform chronic kidney disease education. And the two main models are Ask, Tell, Ask, and the nurse model. We all know from our educational days when we were still in medical school or your respective professional schools, that we always need to verify that the patients have understanding of the information that we are presenting to them. So in the ask, tell, ask, the first step is going to be assess patient understanding. A really quick, simple way to assess that is going to be asking the patient, what do you know so far about your chronic kidney disease? And tell me, what doctors have you seen? What professionals have you seen? And what modalities have you tried to obtain to prevent progression of your disease? Later on, you start providing information, understanding the clinical and socio-economical barriers that our patients might have, and try to adjust the education and the information that we are providing to their health literacy needs. And later on, check for understanding. You can ask the patient to verbalize to you again what was discussed during this intervention, or provide examples of what they're going to do to provide that aversive behavior at hand that we were discussing. Later on, we have the nurse model, which is a good technique to responding to emotion. As we know, chronic kidney disease poses a burden not only to the patient, to their families, and to the people surrounding them. And we, as clinicians and educators, need to be sensitive on the emotions in the room when we are trying our educational interventions. So in the nurse model, it says that the first step is going to name the emotion, identifying what the patient is feeling. Is he sad? Is he angry? Understanding the emotion, respect the patient, acknowledge what they're feeling, provide support, and that might mean that we revisit the educational intervention after on and explore the emotion further. Sometimes these emotions can unravel certain barriers that are beginning to make the chronic kidney disease education not effective. So here we have a figure obtained from the 2024 KDIGO new clinical practice guideline for the evaluation and management of chronic kidney disease. And I want us to focus here on the first area here. As we see, for the optimal care model by KDIGO, it depends on the increased severity of chronic kidney disease. And it starts with all of us, including primary care physicians. So patients who might be on stage 1 to 2, we need to focus that optimal care for our patients on cardiovascular risk reduction and identifying patients who are at risk. Once we start moving on to stage 3 to 4, then we start discussing and promoting self-management and prevention and management of certain complications in CKD. But what if we start promoting self-management from earlier stages? Could we potentially then prevent further progression of chronic kidney disease? And should we later on focus our interventions on further education and promoting those beneficial self-behaviors? And you might wonder if there is a standardized way to provide CKD education. Well, ASN and RPA actually came up with an identity called COPE, which stands for Comprehensive Pre-Kidney Failure Education. As we see here, it is not an approach that the patient or us as physicians need to do alone. We have involvement of patient, primary care, nephrologists, social workers, nutritionists, dialysis nurses, peer support, the community, and our advanced practitioners. So which patients should obtain COPE? All patients with advanced chronic kidney disease, stage 4 to 5, and who are at risk for further disease progression should have an established COPE intervention. As we already identified, many providers can perform COPE, not only the physician. It is a collaborative approach to educating all our patients. Where can we provide this COPE education? It can be anywhere. Actually, some studies that we're going to discuss later on discuss the advances of technology and also remote educational interventions that can help improve our chronic kidney disease education in our patients. It is important to know that this COPE, or comprehensive pre-kidney failure education, needs to be tailored to the health literacy needs of our patients. Here we have a study published on CGSN, which basically discusses the domain and the mission of COPE for our patients. As we see here, COPE encompasses a really big, important area on progression of chronic kidney disease. It not only should teach the patient about the basic anatomy of the kidneys to understand where they're having their issues, but also how chronic kidney disease is classifying, understanding what kidney failure means, and what certain interventions we can perform to slow the progression of chronic kidney disease. In the mission and the message that we want to try to obtain for COPE for our patients is exploring those individual values, goals of care, and health preferences should be established early on when we are doing the intervention. This not only will help us identify what encompasses each and every patient to have all the risk factors for CKD progression, but also it will help us understand what barriers and how can we work with our patients to overcome this and prevent chronic kidney disease further progression. Now, moving a little bit forward, we're going to discuss later on what some of the nutritional guidelines and emergent trends in chronic kidney disease. And we will try to tie it all together to what we have learned so far on what are some of the challenges of chronic kidney disease education as well. So in the new KDIGO 2024 guideline for management of chronic kidney disease, they have some general nutritional recommendations that have. The first is they advise people with chronic kidney disease of all stages to promote diverse and healthy diets, and we'll dive in onto what that means. They also promote greatly a higher consumption of plant-based foods, which have been shown, and we'll discuss also later on, that it slows the progression of chronic kidney disease, slowing the trajectory of eGFR decline, and delaying the need for dialysis through the reduction of certain risk factors such as a cardiometabolic risk. They also recommend people to have lower consumption of ultra-processed foods and utilization of our renal dietitians or accredited nutritional providers. So moving on to the different nutritional groups at hand, let's talk first about protein. So the general KDIGO guidelines suggest that we maintain a protein intake of approximately 0.8 grams per kilogram body weight per day in adults with CKD stage 3 to 5. Now, we'll discuss why this is important. They also want us to avoid a high protein intake, no more than 1.3 grams per kilogram body weight in a day in adults with CKD at risk for disease progression. It is important to know that sometimes they advise us to advise patients to have what they call a very low protein diet of approximately 0.3 to 0.4 grams per kilogram of body weight per day. But it needs to be supplemented with essential amino acids or keto acid analogs. As we know, one diet not fits all. And it is the rationale for the very low protein diet is basically that excess dietary proteins cannot be stored in the body, which might lead to accumulation of protein waste products, such as urea and uremic toxins. This further on leads to increased intraglomerular pressure and hyperfiltration, which in a sense leads to glomerular sclerosis and tubular interstitial injury, leading to further CKD progression. But there is a caveat: if our patients are elderly, at risk for increased frailty, or sarcopenic, we should avoid this very low protein diet and keep a special in hand on patients who are going to be transplant candidates, as we know that frailty and sarcopenia poses the risk to having further worsened outcomes after transplantation. So in this type of population, we would like to avoid a very low protein diet. So why would a plant-based diet make sense? As we know, KDIGO has been a strong advocate to improving plant-based diets in our CKD patients. Basically, it increases fiber, and by increasing your fiber in your diet, you also increase insulin sensitivity, decrease serum cholesterol, and you might decrease serum urea, improving the CKD progression. It also decreases lipids, and as we know, but by decreasing our dietary and serum cholesterol, we can later on decrease microalbuminuria and proteinuria. By decreasing the total animal protein in itself and focusing on a plant-based diet, we can have the opportunity to decrease uremic toxins and inflammation. And that in itself leads to decreased renal hyperfiltration and further progression of chronic kidney disease. All of these key things through a whole food plant-based diet play a role in decreasing blood pressure, inflammatory markers leading to further kidney injury, cardiovascular disease, and mortality in itself in our patients. Now here we have a table also obtained from the KDIGO 2024 guideline, which explains certain studies that have shown what the impact of plant-based foods is in our patients with chronic kidney disease. As we can see here on the highlighted red block, in the intervention and outcome, most of them really invest on what the healthy diet is, which is going to be that DASH diet and the Mediterranean diet as well. And as we see in the outcomes, all of them lead to improvement in chronic kidney disease progression, decrease in the kidney failure hazard, and in composite all-cause mortality as well, meaning that plant-based diet makes sense for our patients. Now, as nephrologists, we would be endearing if we don't talk about our favorite electrolyte, or at least my favorite electrolyte, sodium. So for our patients, KDIGO is recommending a sodium intake to be less than 2 grams per day. And as we know, this has multiple benefits across the board, including lower blood pressure, reduced risk of cardiovascular events, decreasing levels of albuminuria in a chronic kidney disease patient. It is important to know that this recommendation does not apply to our patients with sodium wasting nephropathy. And it's also a caveat to be mindful if patients work around the sun or are severe dehydration to adjust these recommendations at an individual level. Potassium is one of the electrolytes that has caused multiple controversies across all the organizations that focus on chronic kidney disease. As we know, the current dietary guidelines for a normal person without chronic kidney disease for potassium intake is going to be roughly around 3,400 milligrams per day or in men and 2,600 milligrams per day in an adult woman. But the caveat is that they need to have a normal renal function. The reason why there has been many controversies into obtaining a dietary recommendation for our chronic kidney disease patients in the base of potassium is because we know that in early stages of CKD, a high intake of foods that are naturally rich in potassium may be actually protective against disease progression. A lot of the reason why people believe that is because it improves cardiac conductivity, leading to improvement in far further on. Additionally, it's important to understand that not all potassium content that our patients actually eat in their diet is directly bioavailable. The bioavailability of potassium in foods is greatly altered depending on the food group that we are discussing and the preparation. Just to give a short example, if we're talking about green beans, the bioavailability of potassium can be decreased up to even 46% just by soaking the green beans in water and later on cooking them. So there are many interventions that we can provide to our patients to continue enjoying their healthy foods that might be rich in potassium without compromising risk of further hyperkalemia or other adverse events. KDIGO recommends us to implement an individualized approach in each of our patients with chronic kidney disease stage 3 to 5 and the ones who are in risk to develop hyperkalemia and what the general recommendation is going to be for potassium intake. It is important to also know that KDIGO doesn't really mention when to start potassium medications that can prevent hyperkalemia. They only mention in their guidelines that general management should be performed in patients who have a serum potassium of above 6 or above 6.5. And we're not going to dive into details on what those interventions are. Interestingly enough, KDIGO does mention that one of the early interventions to perform in patients with hyperkalemia is actually having a dietary assessment on what high potassium rich foods people are ingesting and trying to adjust that, but to what degree we should adjust it or what level we should be aiming, KDIGO has not come up with a really good number for that. And potassium can be very confusing for our patients. It's found on a lot of foods, especially as a Hispanic myself, we do eat a lot of high-rich potassium foods. So what tools do we have that we can provide to our patients when they're not in the office to evaluate if this food is right for them? So the National Kidney Foundation came up with a program called Kidney Health. And here I leave the link if anybody's interested in sharing with their patients. They put some general information at hand, and they actually put them in contact with a renal nutritionist accredited professional, and they can provide them with recipes and tools to understanding their diet. Not only for potassium, they also tackle other electrolytes as well as fluid management. And Beyond Bananas was an interesting approach performed by RPA. And in that sense, it just provides a basic PowerPoint that patients can follow along. And it debunks the issue that we always tell our patients to eat less bananas when they have higher potassium, and how other food groups interact and how can they improve that in their diet as well. Phosphorus is a really big electrolyte as well when we're discussing CKD nutrition. The general recommendation proposed by KDIGO in their 2017 guideline for mineral and bone disease disorder was that the average range for a chronic kidney disease patient to ingest phosphorus in their diet is going to be roughly around 800 to 1,000 milligrams per day. They also mentioned that it is important to educate our patients on phosphorus additives, and it is important to understand that when they are trying to read the nutritional label, sometimes phosphorus additives don't come only as phosphorus. As we know, there are many additives such as monosodium phosphate, D-phosphate that might appear on that nutritional label that patients might miss as being a high phosphorus food. Important to know as a general rule of thumb is that calcium and phosphorus are often found in a 1-to-1 ratio. So in a sense, we can try to educate our patients that if they know that a food is rich in calcium, it's likely going to be rich in phosphorus as well. KDIGO also mentions that in patients with chronic kidney disease stage 3A to 5D, they suggest lowering a phosphate level towards the normal range for all patients. Now, talking a little bit about the acidity and the alkalinity of food. As we know, some of our patients with chronic kidney disease are at risk of having acidosis, metabolic acidosis. And we know that this can be detrimental not only to the bone health of our patients, but also it can be a marker that might lead us to think that the patients are at risk of further CKD progression. And some of our patients are on what we call bicarbonate supplements. Now, important to know, why it's important to investigate the acidity and alkalinity of our food that our patients take. Well, as we know, sodium bicarb, which is one of the main supplements that we use in our practice to further prevent metabolic acidosis or treat metabolic acidosis in our patients, further on makes a reaction that it actually increases sodium chloride. And by increasing sodium chloride, we not only pose the risk of increasing the blood pressure in our patients, which, as we know, poses a risk to further CKD progression, but also might lead to fluid retention as well. So fruit and vegetables are a good key group to focus on and actually improve metabolic acidosis in patients. Some studies actually have shown that improving the acid-base status of the foods that our patients ingest, we can actually further on help decrease their systolic blood pressure without putting at risk that those increased fluid intake or further detrimental effects of obtaining sodium bicarb supplements. So as we see here, we have a table in which we see what is the basic PRL of some of the food groups. And PRL stands for potential renal acid load. This is a calculation score used by some of our nutritional experts in which takes in account dietary protein, phosphorus, potassium, calcium, and magnesium, and it generates a formula. As a basic rule of thumb, a positive PRA value indicates acid-containing foods, whereas a negative PRA value indicates an alkaline food. On average, we are recommending a plant-based diet because usually plant-based foods have a lower PRA score rather than animal-based foods. So as we see here, for example, if we take an apple, this has a negative PRA score of 1.9, whereas some hard cheese has 34.2. And that can give us a guidance on how to adjust the diet in our patients and treat metabolic acidosis or prevent it as well. So there are many factors that play a role in the nutrition of our chronic kidney disease patients. As we know, some of them might have uremic buildup, might have decreased appetite, acidosis, hypertension, and increased protein degradation and wasting all play a role on what factors affect our nutrition in our chronic kidney disease patients. I want us to also pay important attention to the age and life cycle related factors. And as we'll discuss in a few minutes, people who are at older age, who are at risk for sarcopenia and osteoporosis or decreased physical activity, we need to understand what nutritional guideline to provide to these patients in order to improve their general overall health. So when we are performing these nutritional interventions, what are the main goals of it? One is to preserve kidney function and or further on prevent further disease progression, maintain an optimal nutritional status in all our patients, delay the onset and alleviate some of the uremic symptoms, to correct electrolyte and metabolic and fluid imbalances, to prevent complications, reduce the cardiovascular risk, and overall improve quality of life, which we know that it is highly important for our chronic kidney disease patients. Now, apart from paying attention to what different nutritional guidelines we can post to our patients, it's important to know that malnutrition is actually pretty prevalent on chronic kidney disease. A rough estimate, about 11 to 50% of adults with CKD will have malnutrition, usually characterized by protein energy wasting. As we know, protein energy wasting is a syndrome that was recently classified, I believe around 2017, that consists of metabolic and nutritional abnormalities that often occur on CKD and ESRD patients. And PEW, short for protein energy wasting, has been associated with increased morbidity and mortality in our patient population. It's important to know that early referral to nephrologists is actually associated with improvement in nutritional status on chronic kidney disease patients. For us, as a general rule of thumb, KDIGO is recommended to provide a standardized evaluation for malnutrition in our CKD population and to screen people with patients who have CKD stage 4 to 5, age above 65, poor growth if they have a pediatric onset of CKD, or symptoms that are presented with malnutrition with a validated nutritional tool. There are many validated nutritional tools that are used by our renal dietitian specialists, including subject global assessments, which stands for SGA, malnutrition inflammatory score, which is MIS, geriatric nutritional risk index, which is GNRI. And there is a new one that has been coming up more frequent on certain studies, which is called MUS, which is a renal specific malnutrition universal screening scale. And it has been recommended to be used as one of those validating malnutrition tools for evaluation. It's important to understand that we as physicians need to enable the availability of malnutrition management and aid that early referral for a renal certified dietitian with our patients. Now, what is the renal diet? As we all know, as a general rule, we have heard that patients who are on chronic kidney disease need to go into what they call a renal diet. And that includes multiple different groups such as grain foods, fruits and vegetables, meats, dairy foods, fats, and alcohol. And we'll guide you through what all those recommendations are. But the key thing that I want us all to leave after this Zoom talk is that not one diet fits all, as we will learn further on. As a general rule, we often opt for leaner cuts of meat, which are going to be turkey and lean proteins such as chicken. But if not, we already know that we prefer the plant-based diet for our patients. Now here we have a figure which was from an article published on AJKD back in 2017 that discusses what key nutritional and lifestyle interventions should be posed in patients on their trajectory to chronic kidney disease. These interventions might differ as we continue to go up on that CKD stage, and also the progressive deterioration of that kidney function. As we see, those earlier interventions are going to be focused on controlling disease progression, reducing cardiovascular risk, and controlling blood pressure, which includes a healthy balanced diet, optimal body weight and composition, regular exercising, and smoking cessation. As we continue to progress to our stage 3 to 4, we might focus a little bit more on bone health, anemia, prevented that protein energy wasting syndrome, electrolytes and fluid balances. And as we start moving forwards dialysis, then we all know that we have the help of our renal nutritionist at hand in the dialysis center. Here we have a good table explaining what are the general benefits of each food group in our CKD population. And I want us to focus on the red highlighted block as well. As we can see here, there is limited data regarding fat and alcohol and their effects on CKD and general health being, meaning that at that point in time, it's hard to give patients a guidance regarding their alcohol and fat intake, but we all know that we prefer lower fat diets as well to decrease the risk of cardiovascular adverse events. So why is it important to have this healthy CKD or renal diet? As we see here, foods that come from good groups such as grains, fruits and vegetables, leaner cuts of meat, and plant-based diet all pose certain interactions in how patients obtain their energy. They obtain their essential nutrients, macro and micronutrients, and other important antioxidants, which might need to decrease oxidative stress, improving further and preventing kidney injury. General good health and meeting those psychological and physiological needs is important for patients to also improve generally their kidney function. Gut microbiota has been paid important attention, especially in our hepatorenal patients, that they might have an increased uremic toxin production. By increasing their dietary fiber, we later on increase that probiota and improve the regulation of protein, and in itself decrease uremic toxins. So all of this play a role on our general kidney health. As a general rule of thumb, again, we're going to recommend that protein control diet with increase in plant-based foods. And as we all know, that poses great benefit in decreasing blood pressure, decreasing proteinuria, uremic toxic production, that acid load, and also decreasing the inflammation in our patients. So moving on to our third objective, we're going to talk a little bit about what is the role of a collaborative approach of chronic kidney disease education, and we'll explore some of the future initiatives at hand. So the US Senate started to pay attention to what nephrologists have been saying for multiple years, that CKD education is important. And it wasn't up until 2008 where the House and the Senate enacted the Medicare Improvement for Patients and Provider Act, also known as MEPA. This basically entitles a coverage for 6 educational sessions for Medicare beneficiaries with stage 4 or above of CKD. And as we know, earlier interventions help prevent progression of CKD. So maybe there is some room for public policy in our end to improve this act. Certain pilot projects after MIPA had been aimed to increasing awareness regarding CKD, focusing on prevention and increased screening for the disease. So important to know that all these sessions, in order to be refunded for them, have to be 1 hour in length, and there has to be at least 31 documented minutes when we are performing our documentation. And they started to actually fund them back on 2010. So there was a gap of 2 years before this. They also mentioned that all educational sessions need to provide information regarding management of comorbid conditions, measurements in play to delay the need for dialysis therapy, and prevention of complications. But is it beneficial? Is it cost benefit to provide CKD education? So the national median reimbursement, and this was actually obtained from a study performed by RPA, is going to be roughly around $108 per an individual session. If we are performing a group session for our patients, the estimate of reimbursement for them is going to be slightly over $25. So how as nephrologists can we improve the cost benefit of providing CKD education to our patients? Maybe one way is going to be the value-based care model. As we know, nephrology business is moving more towards a value-based care model. And as we know, value-based care model focuses on disease prevention. And maybe this can be an area for improvement. KDIGO makes a really good general approach on what CKD education is, its treatment, and its holistic approach. And here we see that the first thing that they want us to pay attention is having a healthy diet, physical activity, and weight management. And those all risk factors posing to chronic kidney disease progression cannot be obtained with a proper education. They also want to discuss what optimal models of care are. And in lieu of time, we won't go into details, but I want us to focus on the first figure here. As we know, it's a collaborative approach. Community also poses a big role on how patients perceive their chronic kidney disease and how they can battle them through. KDIGO also provides us with some guidelines on what general educational programs should be, and they basically want us to stratify individually per patient, having a multidisciplinary care approach involving primary care and focusing on improvement of patients' health literacy in order to provide an optimal educational program for patients. Where is the future of chronic kidney disease education? As we know, technology is moving fast, and many aspects to it have been obtained to improve chronic kidney disease education. Some of them are going to be wearable medical sensors, such as basically using blood pressure monitors to improve compliance and manage patients properly. There obviously are some limitations with portability and maintenance. Digital counseling programs, and we'll discuss one which is called the Odyssey Kidney Health, which have shown to improve care delivery models in our patients. And smartphone applications, and we'll talk about some briefly, but we all know that some of our patients might not be so technologically advanced, and this might pose a limitation on how we deliver our chronic kidney disease education. So the Odyssey program was one of those important research performed to see if digital health interventions can be guided to chronic kidney disease education. Odyssey stands for Promoting Health with Digitally Based Counseling of Self-Care Behavior and Quality of Life. It was an automated scale digital counseling program tailored for patients with chronic kidney disease, and it focused on adults with chronic kidney disease stage 3B to 5. Their primary outcome was to obtain a mental component score of the quality of the kidney disease quality of life short instrument. And other secondary outcomes was the GAD score, patient health questionnaire for depression, enhancing recovery in chronic in coronary heart disease, and many others. And basically they saw that patients who had a higher engagement in this program actually decreased the number that they scaled on all those interventions proposed at end, meaning that patients who are self-engaged in their management are expected to have improved outcomes. So what tools can we use as providers? Here I leave you all with a link based from the health.org that actually is a really good tool for providers to perform their own, not only CKD, any educational material, and how to improve the health literacy of this educational materials at hand. So do we have the resources to provide an optimal CKD nutritional education in our patients? This was a study published on CJSN in which I verified to aim what the current global ability of kidney nutritional care services is available to all of them. Overall, they found that about 88%, meaning that 160 out of 182 countries actually participated in this study. And as we see, only 48% of these countries have dietitians to provide kidney counseling, meaning that we're not yet there, and we need your help to improve that. 23% of low-income countries have never had dietary counseling at all, and as we have heard in this talk, is highly important for disease progression. Here we have a figure which shows the disparity of availability of nutritional technicians, nurses, and nephrologists, depending on the income. And as we see here, low income patients have less accessibility to nutritional services. Just as a quick review, we have many patient resources at hand that can help them, not only for CKD general education, but also for nutritional. One of my favorites is AAKP. It actually has a really good cookbook for patients and help them guide tailor their renal diet. Now I want to get this 1 minute left from this talk to talk about what resources we have here at HMH. We are blessed to actually have a dedicated renal nutritionist referral here, and I will leave you all here how to place it. When we are placing the order in Epic, we type REF 399 or REF 398. We post a diagnosis at hand. It could be chronic kidney disease, which stage they're in, hyperkalemia, hyperphosphatemia, or any other management that our renal nutritionist can help us with. And one of the examples of the tools that they actually have, which I found really useful, is they have a kidney-friendly grocery list that they can provide to our CKD patients to help tailor their needs. I hope that during this 1 hour talk, we went over these 3 objectives at hand, and that you left here understanding that health literacy has really big challenges and how important nutritional education is for our patients. I want to conclude this talk with a couple of topics at hand. We all know that health literacy challenges should be addressed when tailoring chronic kidney disease patient education. I leave you all here with the general recommendations, which is going to be a plant-based diet, low sodium, at least less than 2 grams per day, and keeping that phosphate level into normal. A tailored approach to the renal diet is highly important. Not one diet fits all. We need the help of all of you to improve CKD education and nutrition. I want to thank you all for your time, and I apologize for rushing in the last few slides, but hopefully you all enjoyed this talk. Thank you.
All right, fantastic. Thank you so much. Yariana,
Oh, Dr.
great
Edwards, we
job.
can't hear you. I'm sorry if
Oh.
you're talking.
Sorry. Can you hear me now? No? Okay. Well, sorry. Great job. And we'll go ahead and end it because we're over time, okay? Just wrap. Okay. I think you all are able to hear me. Great job, Yariana. For the sake of time, we'll go ahead and just end the session, okay? Thank you, everyone. Thank you.
I'm sorry that there is like I can't listen to anything you're
It's okay.
saying. I'm sorry.
It's okay. We'll see you.
Um, I think she left.